Hi, everybody. Good afternoon. This session will be recorded. This is for your information. And welcome to the last of the first round of this year's asthma self-management education course, focused on asthma applied skills and updates on asthma guideline care. I welcome you, everybody, and I've muted your mics, but as we go along, feel free to unmute yourself and ask any questions, and we'll try to pause at different times throughout the presentation to allow for questions to come in. Let me see. All right, so right now I will hand over the microphone to Dr. Kelly Cowan. Hi, Kelly. Dr. Cowan, sorry.
Hey, Kim. Just wanted to mention you have a question in the chat about the handbook. I don't have an answer to that question, Karen, but maybe we can circle back to that question, unless you want to start with that.
Just if I could clarify, I don't quite see the location. I do see generally is this the state's asthma, the school asthma manual? Who put that question in?
It's in the chat from Christy. So can you talk
Oh,
about asthma emergency plans so we know what to include in next year's handbook?
I see.
So it's on the nomination form, Karen. I guess can we come back to that in there and pull up the form together to look at? Would that work? Christy?
Yeah, we could.
You know,
Yeah, we could. It may also be a question we would have Caitlin Kozis to talk about because it is an internal school document. But
okay.
you might participate in filling some out, so we can revisit it towards the end.
Yeah, let's do that and come back so we can see the form or what they're asking, Christy, so we can maybe help address that for filling out the form, but then figure out what we need to refer to Caitlin, right, for more questions. Does that sound okay?
Yeah, that sounds great. Okay, thank you. So welcome everybody. We'll proceed to show my sharing slides and starting with the presentation. Let's see, let me share my screen. But appearing for you. Good. Okay.
I apologize, I'm on call, so if you hear something dinging here, and I might need to just pause to address it quick. So let's start. We'll do the brief overview here for the housekeeping pieces, talking about asthma self-management education to support students. This is our monitoring slide about the course, and there's 1 credit designated for the course, and please reach out or put a message in the chat so we can come back to that if you're having trouble accessing the site or claiming credits. I think Melissa's been able to get in and been able to access to see the course and see the credits. I think it'll just be getting you, your account set up, and if you haven't already, but we can direct you to that if you haven't been able to claim your credits for the course.
Dr. Cowan, a question had come in last week about whether it was 1 credit for the whole series or 1 credit per session.
Per session, so it would be 4 hours for each session, and then we will repeat another round of the sessions, and you're welcome to join again or join, if you, it'll be mostly the same content, but you're welcome to bring any discussion questions or topics, or we can set aside time to talk through those things and in the next 4 sessions. So it'll be 1 credit per session, so 4 hours for these 4, and same for the next school one.
Great, thanks.
We have no disclosures for Karen and Melissa and I as speakers. And then I think they want us to remind you to claim your credits in 30 days. I know it stays up on the system longer, but that helps with the evaluation piece, and then just making sure everyone's credits are in that 30-day mark. Um, so objectives here, as before, the goals in talking through these pieces of asthma self-management education is to reinforce our knowledge foundation around delivery of care, to support kids with their asthma control, um, to identify kids who have suboptimal asthma control and provide additional supports, to go through updates of the 2020 asthma care guidelines, which are focused on smart therapy and allergies, environmental pieces, and what the updates were there. We talked about the Envision walkthrough, getting nominated for asthma friendly school recognition, and then this can be an additional place for discussion and any questions you have, even if it's not on the topic we're talking about. Next slide. So we're going to go over today um, just reviewing some of the things we talked about before about daily asthma management that kids do at home and school and their asthma action plan, and then screening, identifying kids with uncontrolled asthma, and how to monitor for improvement in asthma control when you're delivering asthma education. Next slide. Okay. And we can go to the next slide. Thank you. So we talked before about the asthma action plan as a communication tool, and this is something when we're creating these in clinic, we review with the caregiver and the patient if that's age appropriate for them. When we're reviewing this is a good time that to go over the medications, how they work, the goals of therapy. And even if I'm not making a new plan, reviewing the previous plan could be a good time to go over these pieces because we're all looking at the same thing. We know what the medications are, and then we can go through adjusting when to use them. Thinking through the pieces, understanding what the green zone is if they're on maintenance therapy, that they're taking this every day, how to know that they're in the yellow zone. So how do they recognize symptoms? We're in the yellow zone. How do parents recognize symptoms? Do they have a pattern to their symptoms? Do they have more problems with seasons, viruses, allergens, air quality? Do their symptoms come on quickly? Have they been easy to manage? And then how is their symptom perception? Are they not noticing things until they're really severe? And how are they doing with recognizing when they're getting sicker? We're in clinic are supposed to be providing these for home, school, daycare, wherever the child will need one. And we certainly can provide updates if there are things that have changed slightly or would make it easier to administer medications at school. I think at least in our clinic, we as providers may all write them a tiny bit differently. There's things that we picked up tips along the way from nurses. Some of the nurses had preferred to have a range of 2 to 4 pups, even just to give some flexibility at school in the yellow zone. And I've incorporated that into my practice because it does tend to make it easier to give a bigger dose if they need it, without any extra stress on the family or seeking extra care if they're doing okay. Sometimes kids need adjusted, versus an as needed or a scheduled dosing for sports, and that might change seasonally. And that's something that's, we would update if that needs to be updated or try to have parents clarify what kids need. When we're going through this plan, this is a good time for us to think about making sure they have prescriptions for home and school. I think one thing, on the school end, if they're not bringing in medications, thinking about what the barrier might be. Is it that they don't have a spacer because they've already met their quota from insurance, or their insurance doesn't cover them and they may be expensive and need some, attention there? Do they, are there insurance barriers that they couldn't pick something up? Or is it just that they, need to reach out to get a prescription? And then this is a time, to go over with the family about self-monitoring control of symptom or their asthma control, their symptoms, adherence to their medications, I guess the schedule working for them, and then their symptom perception. Next slide. So we went over the smart therapy in one of our other sessions, just going over this as an example again, because you probably see more kids with smart therapy dosing, or you may begin to if you have not already. The things to look for here is that if they're over age 12, the 12 and up, their maximum dose over 24 hours is 12 puffs. If they're age 4 to 11, their maximum dose in 24 hours, 8 puffs of the ICS formoterol. So that should be on their plan. There may be some flexibility in how many puffs or how often it's given. You can really give it as often as you need, but their maximum would be 12 puffs in 24 hours if they're 12 and up, or 8 puffs if they're ages 4 to 11. And that does include their daily 2 puffs twice a day dosing. So you would just presume that if they're taking their maintenance Symbicort at home in the green zone, that they've gotten that, and that would count in their total. So this is where it would be important, if they're sick, for parents to know how many doses that they've gotten at school during the day, because there is a daily limit, especially if it's more than the parents were expecting. Next slide.
Before we move to the next slide, do you want to pause here for some questions about asthma action plans, as this is a common challenge for some school nurses, or do you want to wait to the end?
No, I'm happy to take questions or put in the
So
chat.
I know that in past sessions, and I open up the mic to, allow for anybody to address issues relating to action plans, but I think a couple of topics that have emerged in the past were difficulty in getting them from providers and challenges relating to that. Is it about its misunderstanding about it being a treatment plan versus a communication tool? Is it HIPAA? That's one question. And the other is the frequency of updates. So I wondered if you could speak to those and then open it to the floor.
Yeah, I mean, I don't have much more to say. I mean, the patients need one annually, a new one. They really should have a new one if there's changes in therapy. I will make them in my clinic. Even now I'm giving out their school, because school's asking already for forms for the next year. And if the plan is going to be the same anticipated going into the fall, then I'll give them their plan. And then when I see them in the fall, we'll re-up it. So there are some kids getting plans earlier than August. Not everybody can get their plan. Some are on top of it and they're getting their plan earlier. I can just speak to, patients reach out to our clinic, we provide the plan, or we'll refer them back to the primary. If they've been, say years without a clinic visit, we would need to reintroduce them to clinic and get them back into clinic for assessment and a new plan. So we will do our plan, anytime in this range, or they'll call in and we'll get them a plan, and then they would have a follow up. I think we're seeing kids all over the state and Vermont and New York. So they come from various areas, and nurses have had different tips and tricks for their own community. If their kids are mainly seen in one peds office or something, of how to round up some action plans or how their forms work. I'd say, as a parent, my school form says, does your child ever been told they had asthma? Have you ever been told your child had asthma? Yes, no. If yes, do they have asthma now? Yes, no, don't know. And if it's yes, there's upload your plan or send the plan in with your child. And if it's unsure, they may check in with you. And if it's no, they let you be at some of the schools, and at some of the schools they may reach out just to confirm. So it's sort of my general experiences.
Great, thank you. Any other questions or comments about asthma action plans and their use for management and among students? Okay, all right. Just wanted to pause for a minute. Thank you.
I'll go to the next. Thank you. So we're talking about adherence to daily asthma medicine. The main reason for low adherence is thinking that the asthma is more episodic and not chronic. And people often do stop taking their maintenance medicines when they feel well. Sometimes this is okay. Sometimes we do this on purpose when their asthma has been under control for a number of months. We try to take a break from maintenance asthma therapy for the summer for a lot of kids, and then try to get back on board before school starts, or in times when their asthma has been really well controlled for a long time, really make effort to reduce the dose, try to see if there are seasons where they could take a break from therapy. Some kids do improve over time and can have a long stretch or stay off medication in the long term. And most of the time, this is not okay. And that's why we often see kids back, is that they may take something for a little while, or they've gotten over an illness that was quite bad and they've been taking medicine then. But as soon as they start to feel better, they stop taking it. And then there's a cycle of things just being difficult and not able to get over colds easily, having more symptoms. And we looked at this picture before, and sometimes this helps parents understand how the medications work and why. As we talked about before, the airway can remain hyperresponsive after viral illness for weeks or months. So if you're having back-to-back illnesses, you get in a bad cycle of an inflamed hyperreactive airway. Sometimes not the first cold, sometimes it takes a couple colds, but for kids who really have that pattern, we do focus on taking the medications at least for the season. And the normal airway, when parents do that, okay, it's normally not inflamed, the one on the right. The one in the middle is where the problem is. The problem is this inflammation here. And then the muscles that tighten up, the airway hyperresponsiveness that causes the symptoms. And it's a lot easier for things to get bad if there's a trigger, if you're having this airway that looks like the one in the middle where you have chronic inflammation and chronic airway irritation. This can lead to chronic cough, chronic pneumonia, more difficulty with illness, more missed school days. And this often does help, to understand why it takes so long for things to get better and to settle down with inhaled steroids, and why it's important to keep up the medication. No one wants to give their kids medication chronically. It's typically thinking through the risk benefit of the benefit is being able to attend school, to not have symptoms all the time, prevent emergency visits, improve quality of life, improve sleep, and then try to minimize the amount of medications kids need, minimize side effects at the same time. But this generally, I think, is helpful in visualizing what's happening. Next slide. And then other reasons about adherence is, a few of the categories this can fall in is a commitment, concern, and cost. So we just talked about like, why is the medicine important? Because it's treating the actual problem, not just the symptoms, and understanding what the problem is for their child, what goals the medications are trying to meet, and then following that over time can help emphasize the importance of that, and the commitment to taking it. Then there's the concerns, right? That's a legitimate concern that, why do I have to get this medication to my child who's healthy most of the time? Are there going to be side effects? Or my child did have a side effect and I'm worried about trying something else. And then working through to minimize those side effects, trying to alleviate some of those concerns with close follow-up, and then attentiveness to those concerns when they come up. Cost has been a really big deal. And that's sort of led to, the issues that we talked about with access certain devices that may developmentally be hard for some kids and may fail for that reason. And that doesn't necessarily fall on any of these categories. That we've had, people been non-adherent with their medications because they got a device and the kid clearly could not use it and kind of was doing okay, and then didn't reach back out for a while because it wasn't working, so it wasn't worth trying to do. So those cost pieces have become a pretty big deal for families in accessing what they need. Next slide. So for routine follow-up, what we do for clinic, so monitoring kids who are on maintenance asthma therapy is really important. Do periodic assessment of asthma control, and recognizing that pediatric asthmas can be very variable over time. So what symptoms little kids have, things aren't always the same as they grow. That can depend a lot on, family history. It can depend on how many viruses they've been exposed to, size of their airway, and then how stable they've been over time. And So we do take a stepwise treatment approach and frequent monitoring to get things under control and then to minimize side effects. And that tends to be that for symptoms to be under control for several months before making a decrease in treatment. We're mindful of the seasons. If things have been really fantastic for a couple months and we're heading into a nicer season, I still may wean medications, but just being mindful that it takes more than a few weeks to make that decision. And then things that we follow closely in clinic are growth for kids who are still growing, working on reducing exposures to known triggers, preventing exposures. So that would include tobacco smoke exposure, other smoking, vaping exposure with family members. Medication treatment, follow closely, providing education, following spirometry to gauge severity and effectiveness of therapy, working on control of comorbid conditions, and then making sure kids are up to date on vaccines. I'll do a few cases. So the first one, these are, you probably can see the multiple choice on the side, and I took off the red highlighter so that we don't all guess the answer right away. So you can kind of see the previous will be on multiple choice. So 4-year-old child with wheezing after URIs over 2 winters. This past winter, this child had several episodes of wheeze with URIs and had 2 courses of oral steroid and frequent bronchodilators, needed pretty aggressive therapy for those illnesses. The child has no history of chronic nasal discharge, does not spit up, no recurrent bacterial infections. At the time of the visit, the child has a normal exam. They do a positive family history of asthma and allergy. The child is now coughing with excitement and exertion. There's lingering symptoms with the most recent cold, and albuterol does give some symptom relief. So I guess the first question before we move on, we're going to talk about what the next step is. So is this asthma? It sounds like asthma. Say yes. So this would fit the history of someone with asthma. So we do try to think about other things in the differential for a child with recurrent wheezing. But this child's wheezing with colds. They do respond to bronchodilators, they respond to systemic steroids, and they have that added bonus there, the family history of asthma and allergy that fits in with that. And they have new symptoms that fit the symptom pattern of asthma, the coughing with excitement, exertion, lingering cold, still having symptom relief with albuterol. So this is a child that I would want to address their asthma symptoms. We can go to the next slide. So the choices here are no change, continue what you're doing. They have chronic symptoms and they're still going to get some albuterol with colds, steroids if they need it. Number 2, to start treatment with inhaled steroids. Number 3, daily montelukast. Or number 4, 2 weeks of scheduled albuterol.
Everybody can either take their mics off and speak or put their answer in the chat if you want. Being a non-clinical person, I would say number 4.
Do you want me to do the answer?
You can tell me I'm wrong.
I'm gonna call on Melissa. It's not number 4. Anyone want to pick a different one? Doesn't have to be the right answer.
Do I get another choice? 2, number 2?
Number 2.
Thanks, Melissa.
So let's talk about that. So one of the choices is, you can go back up to the slide, Karen, the case slide, and then I'll go through the choices. So it's a pretty symptomatic child who has had these difficulty with colds, wheezing with colds, 2 courses of oral steroids, with aggressive treatment during the colds. And now they have chronic symptoms. So they're coughing when they're excited or exerting themselves. 4-year-olds are very active. So that would be a lot of symptoms. And the most recent cold was lingering, and they are getting some symptom relief with albuterol. So when I think about treating intermittent asthma, so just treating when there's a symptom, versus persistent asthma, so the there's those tables we looked at. We said, well, is this intermittent or persistent? But there's also that sense of this child has chronic symptoms. It's like daily symptoms, like many times a day symptoms when they're coughing, if they're excited or exertion, and they're having lingering symptoms with a cold. So this would be more than intermittent asthma. So this is more than just a brief episodes with a cold that was easy to treat with albuterol, and then they just moved on. So this child has developed more symptoms than that. So at this point, I wouldn't continue the current. And honestly, when they're needing several courses of oral steroids, I also would make a change in their therapy due to their risk of exacerbation. So then we think about the fourth choice was albuterol 4 times a day for 2 weeks. So that's not going to gain them. They're probably going to feel a bit better, but they don't have a new cold. It sounds like they have chronic symptoms. So just getting them through the next couple of weeks without treating the underlying problem won't get them to having good asthma control. So then we want to think about the 2 choices that are maintenance asthma therapy. One is inhaled corticosteroids, and one is the montelukast daily. And the inhaled corticosteroids are the main treatment that works best in kids for controlling asthma, preventing exacerbations, improving quality of life, improving the school. And so that would be my first approach, is to do the best treatment and standard of care for them would be to start inhaled corticosteroids, probably at a low dose for them, based on that history, unless I had some other information. Montelukast daily is a legitimate therapy for mild persistent asthma. The trouble is it just doesn't work as well on its own. So it's not really the first line for that. It tends to be better as an add-on, but I tend not to do both. Some kids have side effects with montelukast. Unless I'm targeting a couple of things that I want to treat with it, I would go to the standard of care and the gold standard best treatment of inhaled corticosteroids. That would have the best chance of improving their asthma control with these symptoms. From there, you have some options if you think maybe adding on the montelukast. Some parent preference played into that, that could do something a bit different. But the best treatment here would be the inhaled steroids. Go to the next slide. Okay, so this is a 10-year-old who has asthma that's already on maintenance therapy with inhaled fluticasone. It's on a medium dose of 110 micrograms, 2 puffs twice a day. They're adherent with their treatment, but they're short of breath playing soccer, even though they're pre-treating with albuterol, and it does help some. They're continuing to be short of breath. They're waking with nighttime cough 2 or 3 times a week. They have had an allergy workup a few years ago that was negative, and they do spirometry in the office, and their FEV1 is 75% predicted, which is mild airflow limitation. Technically, over 80% would be a normal FEV1, but for most 10-year-olds, that's quite low. So typically be well over 100, but this would be in the mild airflow limitation range. Next slide. So the choices here. So this child has poorly controlled asthma. Okay. Yes, you do want to think through whether are they having things that aren't asthma, and they have reflux, they have other allergies that are new. Is there something else happening? But let's say you've determined that they have poorly controlled asthma. What to do to step up their therapy? So they're on a medium dose of inhaled steroids. One would be to increase the inhaled steroid dose to a high dose. The second would be to add a long-acting bronchodilator. The third, and the long-acting bronchodilator, that would be adding it to the inhaled steroid in a combination inhaler, so like Symbicort. So let's say we're at change from Flovent to Symbicort. The third would be to add montelukast daily, and the fourth would be to treat with oral steroids for 5 days. What would you like to do for them?
We have one vote for number one. I was going to say, from a non-clinical point of view, number two. We have another vote for number two.
I'm good with those votes. Anybody else want to vote?
Sure.
So let's talk through these options. So thanks for having the case up. So this is a child has asthma, who's on a medium dose of inhaled steroids, who's symptomatic with exertion and at night. And you've already thought through adherence, and you've thought through comorbid conditions, and you've realized you want to step up the asthma therapy. So the one of the choices that I would eliminate right away is the oral prednisone for 5 days. This is someone who's not experiencing acute exacerbation. That would not be a helpful or safe treatment to just treat them for 5 days for these chronic symptoms. So then that leaves us with the choices of increasing their inhaled steroid dose, changing to combination therapy with inhaled the ICS LABA, so adding a long-acting bronchodilator, like changing to Symbicort, adding montelukast daily. So those would be the things of adjusting their maintenance therapy. I would pick number two, which was adding the long-acting bronchodilator. Of these choices, that would be my first choice for this child. The other choices would be, talking through with the family the other options and getting input on family preferences and symptoms. So for kids who are having poorly controlled exercise symptoms and nighttime symptoms that are somewhat responsive to albuterol or really responsive to albuterol, adding the long-acting bronchodilator tends to help really well. Sometimes we can overall lower the inhaled steroid burden for them with that. And that tends to be the most effective treatment over increasing the inhaled steroid dose or adding montelukast daily. For kids that, I would think about increasing the inhaled steroid dose if there was a contraindication to a long-acting bronchodilator. It doesn't happen very often, but I've had to do that before if they, for some reason, can't have the LABA. And if there was a contraindication to adding the montelukast, then that's something we would think through of whether doing that. But overall, it's nice if we can try to reduce the inhaled steroid burden when we can. And then thinking about the montelukast, that doesn't tend, even in this situation, tend to be the best add-on. A lot of parents are not, they don't want to take that risk with the side effect profile. I do use it for exercise-induced asthma as an add-on, and it sometimes helps with nighttime symptoms. This kid's having symptoms both of the time. It may or may not work as well. And so this would be a family discussion about the montelukast as well, whether other symptoms that adding that would help more. And then I think overall, as far as what's the effective therapy, it would be the most effective therapy is changing to an ICS LABA. Okay, then our next one is our last, I think that's our last case. It's a 13-year-old with severe asthma who's chronically on Dulera 200, 2 puffs twice a day. That's a pretty high dose. That's the highest dose we have for that. And tiotropium, which is Spiriva daily. Their adherence at the time, discussing in this case is kind of fair. They are adherent with taking montelukast, they're adherent with an antihistamine, and they're adherent with taking a nasal steroid. Their allergic rhinitis symptoms are terrible. And chronically, they're using albuterol 3 to 5 times a day for shortness of breath and cough, and they do not go anywhere without their albuterol. They're really afraid to leave anywhere because they're so short of breath. They do get symptom relief. It's not really lasting more than a couple hours. And despite this fair adherence with the Dulera, this child has had some streaks of good adherence, and their symptoms really weren't that much better. So next slide. So next step for them, the first choice to offer school administration of their maintenance Dulera, because their adherence is not very good. The second is smart therapy. So that would be to take their Dulera as a twice a day maintenance, plus when they're having symptoms, instead of albuterol. The third would be consider adding a biologic for their poorly controlled asthma and poorly controlled allergies. And the fourth is offering all of the above. Yeah, I like those choices. So this is someone we did number 4, all of the above. So because some of these take time. So this child we talked about in the case, as far as offering the school administration and maintenance therapy, they declined because they were newly in the middle school. They hadn't, met the nurse a lot yet. They didn't want to leave class. It seemed really different than elementary school. And the child's like, no, I will work on that at home. I'm not going to do that. And we also did know that their symptoms were really quite terrible, even when they had good adherence with taking it twice a day. That the school administration often is a really great option in this situation. Often gets kids quite a lot better. It can be really life-changing. The second option of smart therapy we did start for this child, and this child was symptomatic in this way kind of before the time where the asthma guidelines were updated to be able to do this therapy and get it covered by insurance. So we were trying to have them, fill 3 months at a time, stockpile some medication because it was in the GINA guidelines prior to being in the NAAPP guidelines. But that was actually really changed a lot for this child to just carry the Dulera in a spacer in their pocket instead of the albuterol. We didn't take away the albuterol right away because that'd be scary for them. But having the Dulera, they said, when you have symptoms, that's your main medicine. Take that when you have symptoms. And they ended up on Dulera 3 times a day, essentially, and that kept things okay. Overall, they needed more treatment. So we, over a number of months, because they had to get labs and it was hard to get in for clinic and then waiting for insurance approval, did add a biologic for them to try to tackle the asthma symptoms and the allergic symptoms as well. So for this child, all of the above. So back, we review again the goal of assessing asthma and then monitoring for asthma control is to reduce the impairment, so improve symptoms, and then reduce the risk, so risk of exacerbations, risk of side effects. And the goal would be figuring out, for kids, figuring out, well, what's the goal for them. And obviously, certain things for everyone, like reducing exacerbations, but if there's kids who aren't able to play sport that they enjoy, if they're having, waking up a lot of night coughing, those sort of things are symptoms that we can watch for and really look for improvement and adjust therapy around that. So the asthma control test, I think you mentioned, Karen, we have a couple places that we can look at that during this talk. So I don't know if you want to pause here and look, if we want to come back to it.
Why don't we come back to it? Yeah.
Okay. So we'll get back to this link of, there's, multiple places to do this. This is a nice one where you can take the asthma control test online. Of course, it does not encompass every bit of asthma care, something watching over time. Just because your asthma control is great today and you're not on medicines does not mean that you don't need any. It's taken into the context of your long-term symptoms when we're deciding about asthma therapy. This is really helpful in following it over time. Next slide. So we'll talk about, before I hand it over to Karen, that, we talked about adherence and how that affects asthma control. Just to review again, that it's mainly social factors that affect this. And we can think about what things you see at school that make living with asthma more complicated. I think the main thing we see in clinic now is the access to medications, whether it's the devices that they need or having a high deductible insurance and asthma medications not covered well. They're still super expensive. And then probably supervision issues and just bandwidth for parents to make sure the administrations are administered. Over time, I think we make pretty good headway on just close follow-up and understanding what the medications are for. But are there things you're seeing in school that make things hard for kids? That's okay. And if you think of things do you want to mention, you can put that in the chat too as we go along. Okay, I'll pass to you, Karen.
Thank you, Dr. Kelly. Yeah, so one of the situations we've seen in the data is that we see the statewide data shows that about 60, let me go to the next slide first, that there's about 61% of children that have uncontrolled asthma, and I think 51%, this data is a little bit off, is 51% had an exacerbation in the last year. So there are a lot of kids with uncontrolled asthma at any one time, even if they're under doctor care. So the question is as you see your students coming in, those with asthma, what are things that you look for? And this one, I think, Dr. Kelly, you should take as it's more clinical in terms of what might be top screening criteria, or Melissa, of Dr. Kelly, of what might be indicators that they should be looking at for those with uncontrolled asthma.
Yeah, I think the things that, tend to stand out to us when we're seeing kids is obviously if they've been in the ER for asthma, that does bring some attention, in the hospital. And sometimes kids going to the ER, being in the hospital for asthma, maybe their very first exacerbation, there actually may not have been like much in the way of a warning sign. They might have been like really fine. Sometimes they're like, well, in retrospect, they did have a chronic cough or things, and that probably was something leading to it. But sometimes we don't know. But when they've had that, we do know. Or if they have a history of not great control of asthma symptoms and end up in the ER or in the hospital, that's a big deal. And really need to focus in on their control. I also think that sometimes the ER visit it's because of timing, what time of day, or it's 9 o'clock at night and they can't go to the peds office, and it may or may not be as severe. Then we do think about, well, how often are they having an extra visit in their primary office for asthma symptoms? And then the number of courses of oral steroids, which might line up with some of those visits. And thinking about what symptoms kids are having, exercise symptoms can be pretty important to. That's not that typical for kids, and often that can be brought under control with maintenance therapy. If kids are needing that whenever they play, they're short of breath, and that's something having a bit closer asthma assessment might be warranted. It is okay for them to get exercise pre-treatment every time, but I think it's just, whether the sense of, if I have a patient that has, exercise symptoms, every time they play, that's something I monitor more closely in clinic. And is that getting under control? Does that seem reasonable? I have one patient who's been like pretty maxed out on therapy. They're on high dose inhaled steroids, they're on Spiriva. They're pre-treating with albuterol and having to stop to play. And this has really been years. And so to get the asthma under control and eventually looking towards, maybe starting a biologic for them. But they're really doing okay. They're getting close follow-up for that. And that's what we can do to best manage their symptoms. And things are actually well controlled in terms of their lung function. But they're getting pretty close follow-up for that. And it isn't someone, if they were needing treated, twice a day with albuterol for exercise symptoms, that's not someone I would, just have out there and not be seeing back often. So some of those times, like if they're in a lot with a cold, need extra, that's pretty unsurprising. But some of those symptoms are things that I would alert me a bit more as well. And how often that's happening when they're not sick. Melissa, I don't know if you want to comment on some of these.
No, I agree. Exactly. It's how we kind of get them through is either, referred through, the ER, or even the school nurse will call too and say, hey, look, like the asthma action plan doesn't have, exercise checked off, but they're coming to me every single day before gym and they really need it. Is this a change? Is this a concern? Or, so it's nice that you kind of bring it to our attention and we can check in on the family and make adjustments to the action plan if not, or see what else is going on with the family. So I know that that's another way we kind of find out too, is the school nurse saying, oh, little Johnny is coming to us every day. That's doesn't, shouldn't be that way per the action plan, and he should be under better control.
I think we're not on the front lines of missed school stuff. We hear about it later. But I think that's something, if kids are out of school a lot for their asthma, then especially if they're not on maintenance therapy, that's a pretty big deal, and that should be a fixable problem. And I think like a lot of families, I think we've gotten called into care conference and things for like just terrible attendance. And I think sometimes families have worries like, well, I have a sniffle and during COVID, no one let me come, but that's not what's happening. We want people to be at school. And we're sort of back where that asthma plan actually can facilitate you going to school if you need, to do your yellow zone albuterol and you're feeling amazing, participate in the day, and that keeps your symptoms under control, then that's okay. And then, we try to work with parents on how to use the action plan at school and how to work with their nurse to get advice about timing, if, and how to work that into their day if they're getting over an illness. But I think we hear about the missed absences on the late end, and you guys may hear it like in the middle somewhere, because if they missed a couple of days, they're probably just really sick. But if that becomes a pattern where they're just out a lot or can't get back after an illness, sometimes adjusting the therapy really can make a big difference in the missed school part, and we really want to help with that.
Well, thank you. And I think the key, some of the key words in addition to the clinical care and the, is that school nurses tend to be on the front line. They're the first to see on a daily basis. And so with this number of, kids who are facing either risk of exacerbations or at any one time with uncontrolled asthma, those who have that criteria, match that criteria, or others that you observe miss school days or coming into your office regularly would be key signs that you've got an uncontrolled asthma kid. And so in addition to that clinical care, a key thing that you can do to stave off some of the more adverse events, like those urgent care visits or emergency department visits, is actually to deliver asthma self-management education. And the thing about asthma, this extra education, the supplemental education beyond the doctor visit, is that it has been shown to improve and sustain asthma control for 1 month, 3 months, up to 12 months. And we do see in the data that it has reduced hospitalizations, ED visits, urgent care visits, and reduced missed school days. So it can actually improve quality of life, and it makes a difference. We know that for school nurses delivering asthma, one of the key factors of success is setting a start date. Identifying a student and setting a start date. Like, when do you want to start, delivering this packet? I just want to show you a quick graph of various kinds of asthma self-management education asthma programs we've run. And you can just see just from the graphs in various settings, different models, you see from visit 1 up through either visit 3 or visit 5. And the orange is a follow-up visit 1 month after, in some cases, up to 6 months after, you see asthma control continuing to increase. And so it's not only sustained, it's not only increasing, but it's also sustained over quite a number of months. And you've seen this data at the bottom, which shows efforts by school nurses delivering asthma, and you see a very similar improvement. And then, of course, you see improvements in skills, the spacer use and proper inhaler technique. And so the audiences, this is great for those with uncontrolled asthma, high-risk families, families who may not have high health literacy and need that extra support, or families who live in poor housing stock and seem to have regular events or multiple kids with impacted by asthma, and other issues or challenges, or have difficulty having regular maintenance of their medications, regular adherence. So those would be great identified students who would be, might be supported by ASME. What it is it's additional education. It's at least in 2 sessions so that their learning can happen and be reinforced. It involves improving skills like proper device use, and knowing how to kind of self-assess or follow the action plan. And it improves asthma knowledge. What is asthma? Basics about understanding the knowing symptoms and triggers, and then what additional supports there might be to be able to offer those, either translated materials or handouts with pictures of the lungs, whatever they need to understand things better. And usually for school programs, we often just have very simple, metrics that can be used, but you want to do the assessments, as Dr. Cowan was saying, but these are simple assessments to periodically check in, and oftentimes an ACT score, or actually having them do a use of device in front of you so you can determine whether they are using the device properly. And then you can do reinforcing coaching and demonstrations for them. This set of sessions have been structured to outline ASME. So we started off with overview and then asthma pathophysiology, and then we went into asthma medications in session 2, asthma triggers, and asthma daily management in today's session. So you've already gone through what the basic content might be, and we have available for you some tools and resources if you were to start with one student with uncontrolled asthma and deliver ASME in like 2 sessions. You could cover it. And we have these videos that are available, these 5-minute videos each on each topic. And then we have 2 demo videos on use of a spacer and use of a mask with spacer. Those are just 2 minutes long. So you could request those if they would be something that if a student came to your class, to your office, you could show them 1 or 2 of them while they're taking their medications, and then send them off, and do the next round in another session. And the other thing we have is the Ask Me in Schools packet, which many of you received. And this includes an intro page, which has a checklist, and it's organized by both knowledge, a knowledge checklist down here on these 4 categories, and a skills checklist. And so you could use that instead of the videos. And then the packet includes 2 forms, which include the first form is the main delivery of Ask Me, and it includes your session 1 activities, which is to write down your school identifying information, de-identified information, like an initial for your student, and then some of your observations about what makes it flag the student that this is an uncontrolled student, number of ED visits, urgent care visits, or missed school days. And then down here is 2 or 3 boxes down here at the bottom, which are where you would actually deliver material, and it says what date. And then document the asthma control test score and whether they did a proper device use. And at that point, you know, if they did it incorrectly, you would provide coaching and you just mark it down. And then you would just check off and put the dates of when you covered the content of those 4 categories. And then at the end, you would do your second session and record those dates in the same section. And then you would write down a post-assessment, like has their asthma control changed, and or has their device use techniques improved. And that's it. That's the completion of the ASME core delivery. Oftentimes we want to see if asthma control and technique has been sustained over time. And so a second form is available for you to do a 1-month follow-up. After 1 month of completing that, then just do a quick follow-up. And really, it's just down in here that you would write new information on the control score and proper device check. So that's it. And then if you haven't seen the asthma control test, let me pull that up. That was what Dr. Cowan was showing before. This great link, I can see if I can put it in the chat for you, and you can pull it up yourself and give it a go. Do that. But it's basically, I'm going to see if I can't pull it up now, and we'll go to it real quick. It allows you to, this is one of the best practice tools but there are others, TRAC, ATAC, there are other instruments. But when you pull up this particular link, you get this page, and it has down here, who's taking the test. Are you taking it for a child, or are you taking it for an adult over 12 and under 12? And so let's do under 12, and you just go to next, and you start taking you go to this next question, begin the test here. And so here are the questions. You know, how's your asthma today? Ooh, it's not good. Next. How much of a problem is your asthma when you run or exercise or play sports? It's a big problem. And do you cough because of your symptoms? Yes, some of the time. And then you go, I'm just making these up. Do you wake up during the night because of your asthma? No, none of the time. And then we go, during the last 4 weeks, how many days did your child have any daytime asthma? So this has involvement by a parent to help with this. And so I'd say, 4 to 10 days. And then during the last 4 weeks, how many days did your child wheeze during the day? About 4 to 10 days. And then during the last week, how many days did your child wake up? No, not at all. And here pops up a child's score is 16, 0 to 19. Your asthma symptoms may not be well controlled. And in this case, usually these tests are bifurcated. It's well controlled or uncontrolled. This has a trifurcated version of it. And it puts you in a kind of a red, yellow, or green zone, but it's not well controlled. So therefore, it's in the category of joint combined, which is uncontrolled. So this person would be well suited for receiving asthma self-management education. So very easy, very simple, nice little tool that you might want to use. And then the other skills, in addition to the assessment of asthma control, you would perform a check on asthma device use, and it's usually best done by a show back. For older kids, you could do a demo and say, you know, do you do it this way? Where do you have problems? And you could do a interview check on proper technique, but it's better to do a show back. And so if you haven't received the packet yet, please put a note in the chat and ask for that and give me your email and I'll get it to you right away. Set a start date and a student that you want to work with and deliver it, and then you can use it to earn points. Not only can you earn points for participating in this Ask Me network, but you can also get points for delivering and completing an Ask Me form and send it back to me in a de-identified fashion, and you can get points for completing Ask Me delivery. And then you want to go and nominate your school for asthma-friendly recognition. And if you haven't done that, it's pretty easy. You just, here's another, let me see about saving that. It didn't work. See, if you go to the department, you go to health promotion and chronic disease prevention, the asthma page, and then asthma-friendly schools. I don't know why the regular link didn't work. And then once you get down here, it gives you some basic information about that. And then here's the online form. And when you click on it, you actually go into the form and you can start now. And you can enter your basics about the school, your information, your contact information, so I can follow up with you if need be, your school information. And then you just start going through a bit on best practices. This is a lot about the school background, and I have to put, some of these are required. So if you don't know it, just put a question mark in there and move on. And that would be the way to go through. And the other thing is you can have multiple nominations from different persons in your school and submit them separately, and they'll be, combined. So grounds crew could do it. And so I see that we're at the end of time, so I won't go further. We do want to go back to the question we had about the emergency plan that's in asthma-friendly schools. That's really a staff plan so that a school nurse might draft it and work together with leadership to have a plan in case an emergency exacerbation occurs. What steps would you take? What if you are not there? What steps would you take? And if those are outlined in a very simple fashion, I think there's another point if you train staff on an emergency response. So when would you call 911? What are those signs? Just simple, basic, do these steps, and where does that sit? I hope that answers your question. If you, I don't know if you can save the progress online. If not, just go back through and put question, a question mark or a dot or something until you get to the question again. And just write down at the top your name or the school name, and I'll know that they get integrated. So, you can get out and then go back in. You might have to start over, but just put, whole spacers until you get to the question you had left off at. And the deadline for nominating your school is May 31st, so it's coming up. And then feel free to reach out for any additional resources that you might need. Dr. Kelly, anything else? Any last questions as we close? We are going to take a break next week due to spring break and then start up this round 2 in 2 weeks. And so look forward to seeing you in 2 weeks. And
it'll be the same content, Karen, going through. So I think if you guys want review, or please feel free to join again. You can still get credits, and you can bring new questions or things as they come up as you're working with students. Okay, so hopefully,
and very applied focus. So we could actually walk through and nominate your school right then and there, or we could, fill out forms right then and there. So, or if you had topics, we could orientate those to your concerns or issues. Well, thank you, everybody. I hope you have a great, enjoyable, sunny rest of your day, and see you in 2 weeks from now. Take good care.